This
You know,
conference will now be recorded.
Ooh.
okay, so now you're recording. I'm gonna, actually, before I go slideshow mode, screen share. Let's see, start sharing. There we go. I'm gonna make sure I do it right. So I actually put slides together for this.
Ooh, I love it. I love it.
And can you guys see those slides?
Mhm.
Okay, and that's like, you don't see like the timer running and everything. You just see the full slides. I want to
Nope,
make sure I'm
we're
showing the
good.
right screen. Okay, perfect.
Right. I'm gonna mute
Uh,
myself and you go.
oh, that's great. Thank you, Paige. Um, so yeah, I put some slides together this week, and I figured, we could just kind of run through some things. Paige asked me talk a little bit about just updates from BDC and just kind of like what's life like in 2020 with COVID, and what's that look like for diabetes in Barbara Davis. So just to give a little perspective here, from the folks I saw on the call, I see the Aikman family, and I see Frankie and her family on. So you guys know me. I don't know this here's family. So this is an introduction here. This is my family on the top left there. That's Peter in the middle. He is now 6 weeks old. I think he was maybe 2 weeks at the time we took that one. We had a friend come over. But I have four boys, and the other three are doing homeschool right now, just like I'm sure you guys are experiencing. So as I'm down in the basement trying to do telemedicine, I can hear screaming and yelling through the vents and stomping and all that kind of noise. So I think that's definitely an experience that we're all going to remember trying to homeschool our kids, and hopefully, if anything, teachers are going to get paid more on the backside of this as we recognize what work they do for us. I've been with the Barbara Davis Center for, it'll be 7 years this summer, so we can round up, so over 6 years now. I do quality improvement at the Barbara Davis Center, and that is, um, it's definitely the kind of thing that I can nerd out on that most people find really boring, but I can just dive into detail and just really enjoy working with our team and making our team more efficient, and finding opportunities to do things better. And I think that the attitude we take is that there's always something we could be doing better for our patients. We could be deploying our team in a smarter and better way, and if we're more efficient, then we use our team members better, then that we will take better care of people with diabetes and make life better, and that's our goal. So I get to, as a part of that job, I work a lot with our medical record system, which is usually something that doctors hate doing, and you see them complaining about medical records, and I see the amazing potential for what we're going to be able to do with electronic medical records. Uh, American medicine went on these electronic systems about 10 years ago, when the federal government really cajoled us and put a lot of financial incentives out there for us. And we haven't really harnessed that capability yet. I was just telling Paige and Dana a few minutes ago as we were getting on that I did telemedicine today, and the telemedicine software was embedded within the medical record system. So it was a really slick setup today. It was a children's clinic I did. We're using a different setup of BDC, but that's a lot of work I do, and the foundation has helped us out and helped us with a pilot grant a couple of years ago. One of my other interests is examining and trying to understand the rate of decay at new onset. We had a paper published a few months ago, and there's not a lot that we've been able to do other than to raise awareness for it, because it's a really hard problem. I think that screening studies are going to help us get to the place where we can do large scale screening. There's a lot of really good work being done at the center, looking at cost effectiveness, as well as just understanding what the profile of that screening would look like and what the cost would be. I'm involved in an artificial pancreas research team. I don't lead the efforts, but I usually help staff some of the studies, and I'm involved in some of those, especially as it intersects what we do in clinic. I think the coolest day I've ever had at work was when we did a ski camp study a few years ago. I got to go skiing and call it work. I never thought that would happen. I'm also the medical director for Camp Colorado, and 88 camps were canceled this summer. So I kind of feel like summer was canceled because that's a really wonderful week, and it's an amazing team of people that we get to work with, and it's a really wonderful week we get to give to the kids. My wife Carol there, like I said, she was just getting back to work this week. She's a dermatologist, and so it's a lot to balance. 4 kids. We didn't really plan on having 4 kids, but then this wonderful blessing came along. So it's a wonderful challenge that we're trying to figure out right now. So at the Barbara Davis Center, just one of the questions that I wanted to speak to was, some of the challenges we're seeing with our patients. I think that I think that all American families are experiencing this. Kids are out of school. There's less physical activity. They have later bedtimes. They're sleeping in a little bit. Sometimes it's a blessing and you can just like enjoy your cup of coffee before they get up. But a lot of especially the middle schoolers and high schoolers that I'm seeing in clinic, when I look at their Dexcom report, I can see that breakfast is somewhere around 11:50 in the morning, and then bedtime is somewhere around 1 a.m. And that's not all bad. Teenagers are really, we know that they're wired to sleep in a little bit later, and it's almost cruel that they start schools, especially high schools, at 7:30 and 8 in the morning. It's really hard for our kids, and so um, but sometimes we see that play into blood sugar management too, when there's just a lack of a schedule and the physical activity. I take care of a lot of kids. I love telling kids recently diagnosed with diabetes that, you name a sport, I take care of somebody who competes at a high level in that sport. And now all those kids are not competing. And I know Frankie's a swimmer, and I've seen Beth post about that recently. And I know that insulin needs are really different when you have the difference between the active weeks and the non-active weeks. And then even if you have something like swim practice twice a week, the insulin need difference isn't just the day of, but that bleeds into the next couple of days beyond, usually when you're going to be active again the next day. So some of the recommendations that I've really been trying to focus on with my patients and visits is to, find a schedule and to find some physical activity. We have not had a large number of parents being furloughed from work who are having prescription needs yet. I think some of the furlough programs they're maintaining benefits at some of the workplaces. I don't know what it looks like, countrywide or across the state, but this is something we anticipate is going to be a major challenge for our patients. So I know Dana has brought this up with us. The Helping Hand program really provides wonderful support for our families who need insulin and supplies, but $100,000 doesn't go really far for insulin, because it's so stinking expensive. So even a lot of money being raised, we're concerned about how many people we're going to be able to help. And so those are questions that that are being asked that I don't know if we have great answers to yet. One of the concerns, with if people are losing insurance, I think that we're probably approaching 20 million Americans out of work right now is with the lack of insurance. If they can't get their supplies and if they can't be seen in clinic. And, for these families here, the Aikmans and Hodgson family, I know you guys, if you went a little bit longer without seeing me, I know your kids would be fine, because I know you guys well. But you guys come and see me in clinic. The families I'm really, really worried about are the families that we really struggle to get into clinic twice a year at a good time. And then we actually have to use prescriptions as a little bit of a stick to get them back into clinic, because if we just refilled their prescriptions at any point, they would never come to see us. And yet these are the families that really need social work interventions. We do have to make CPS reports. It's not something fun for our team to do, but we don't do that, of course, to be punitive, but we do it because we know families need help, and we're really concerned that families are stressed. I'm sure with the stress at home that alcoholism is going to be a problem that we're going to be fighting. And I think alcohol use rates are going to go up, and we're going to see. I know the American Academy of Pediatrics has been concerned about rates of child abuse going up during this time because we're at home and we're angry with our children and we're stressed out. I think I heard my wife say the other day that she was so angry. She said, "I hope COVID takes me," and I know she didn't mean it, but just I think the stress that we're all facing. We really want to be there for our families and be able to help them identify either blood sugar or diabetes management goals, or if there's something a little bit larger like healthy eating or family health that they need. And so we're concerned that having a lack of connection with some of the families is going to lead to some negative outcomes. And then last week of March, the whole world transitioned to telemedicine. I was talking last week to a colleague in Perth, Australia. We had a really nice conversation. It was really nice comparing notes. They only have about 40 some confirmed cases of COVID in their country, if I remembered what she said correctly. But they went to telemedicine and they're social distancing like us. And comparing notes about the transition was really interesting because we're on opposite sides of the world, and yet we handled it the same. We just said, oh, now we're allowed to do telemedicine home to home, and we have the technology, and let's just do this, and let's get our people trained, let's get the tech ready, and let's get our patients onboarded. And and let's do what we can do by telemedicine. And so it's really amazing that the whole world is transitioned over to that. So like I said on the last slide here, these are my recommendations for families right now. It's just, it's okay to have a little more screen time. Again, American Academy of Pediatrics has, said you guys can chill out. It's really nice that they do that, because a lot of times they make me even feel like a bad dad, as tight as some of the recommendations are. I've been recommending to the kids that they should help out with the dishes, just because I see the dish pile up. Like, I go get to find a plate and they're all in the dishwasher. And we run that thing once or twice a day at our house. So I'm asking my kids to help out a little bit more around the house. You guys have probably seen this study circulated on Facebook, the Belgian Dutch study, with this, really nifty graphic. This study was completely ripped apart in some of the physician groups that I'm a part of. There's a couple of virologists and epidemiologists and folks who commented on it. But basically, if you haven't seen this study, and I use that quotation marks, it was a news article based on a little bit of aerodynamics lab science that was done by some guys, I guess, in Belgium or the Netherlands. And the case they made was that when you're out for a jog or riding a bike and you're moving at velocity, that you could be potentially spreading the virus, I think 30 feet or more behind you. And so when we go socially distance, like, that's the last thing we all need, is our community Facebook groups, complaining about the people, being within 15 or 20 feet of each other when we're all like walking our dogs. And none of us are out of town on vacation. Nobody's work traveling. Nobody's skiing. We're cooped up in our house. And then they recommended that we get on the road to run. And the last thing we need is people hit by cars. But there was no virologist consulted on that study. They used spray nozzles. They didn't investigate like what's an infectious dose, like how many viral copies. It was a very theoretical lab-based investigation that I think has been submitted for peer review now, but just in the format that it was and the way they listed, there's going to be a lot of limitations that weren't spoken to in the study. So as when my patients have brought this up, and like, I'm afraid to go out of the house. I've had a few families tell me that, and I'm afraid that I had family tell me last week that, my son doesn't want to go out because he doesn't want to get COVID on his shoes. We've read that. And yes, there was a study recently looking at the amount of virus on the soles of ICU workers' shoes. And yes, that's a concern. And I think the hospitals need to pay attention to that and put like, sticky stuff down on the floor, change your shoes when you get home. But if you're just going to go out for a walk in the sun on a windy day, I think you should get out and go for a walk, or go ride your bike and go for a jog. And I don't think we should freak out about walking within 6 feet of people. Try to distance as best we can, but I don't think we have to do what I've seen neighbors, jump out of the way and waft their face. I think it's a little bit of overkill. And I think from a health standpoint, the greater good is, if you have diabetes, get out and move around, stay physically fit and active. And that's something that I tell my patients year round all the time anyway. I actually put this slide together with a different background this morning for the T1D exchange. We're going to be doing there's a research study we've launched. The exchange, if you're not familiar, is a network of over 80 diabetes clinics in the US. And it's funded by the Helmsley Foundation. And there's a lot of really great type 1 research that's come out to tell us about, what's the current state of things in the US, psychosocial, pump and CGM use, a lot of questions we can ask, but a lot of, they've also funded a lot of the device studies, and a lot of the devices that your kids are using now have been funded from Helmsley and done through exchange sites. So one of the things that we hope to do is to understand what this virus, what is the impact of this virus on people with diabetes, with type 1 diabetes specifically, because when you look at the data from China, there's and some of the early data from elsewhere, that the pediatric severe illness and death rate was very, very low. And so that's one of the challenges there, is that, if there aren't children dying in their large cohorts of thousands of patients, how many people had type 1 in those cohorts? Probably some, but is enough to draw a conclusion about type 1 diabetes. The type 1 rate in China is about 10% of what it is in the US. So they throw around the term diabetes, really probably talking about almost an exclusively type 2 group. And when you think about older folks with type 2, it's not just having type 2 diabetes, but those older folks probably had lower fitness rates and higher rates of obesity and higher cholesterol and past heart attacks and things like that, that made them at higher risk. So our message right now for families is ISPAD is the International Society for Pediatric and Adolescent Diabetes. It's a great group to look to for guidance. They talk about anecdotal reports, and I've talked to like friends of friends in the community about what did the Italians see in February and March as COVID was ramping up, and the anecdote from them was that they were not seeing higher rates of severe illness in their type 1s. But that's anecdote, and we really need large studies and a lot of data. JDRF, says current evidence suggests that if you're doing well, you're not at higher risk. So, I mean, my message for my patients is I don't think you have a lot of reason to have extra concern. I think that it's perfectly appropriate to be cautious. I've had some families ask me, can you write a letter? Because there was one mom who was a nurse who wanted to take time off of work and go on leave because her daughter was high risk. And I was all right saying that because I can't say it's not high risk, but I think that what we can say is I think the risk is pretty similar to the population risk. And I think that now is as good a time as any to say, let's manage blood sugar as well, because it is going to set you up to do really well. American Telemedicine, we were ready in terms of having the technology, but it was literally like the decision was made on a Tuesday. We're going to finish out the week with visits and we're going to telemedicine. And I said, hey, I have a Highlands Ranch clinic on Thursday, and I've got a lot of families who are really engaged, and I bet this would go really well with them. I'd love to be your first telemedicine provider. And so our team got my patient scheduled. We learned a little bit in the process. But when normally, we have 3 girls at the front desk at BDC, and then we have 2 women who are working check-in, MAs, 2 or 3 doing check-in. If you take out the person doing vitals, which is usually Tavia, so we're not doing vitals now, so I'm not counting her, but it's usually 5 people to get you in a room, to get you scheduled in a room. Right now that's 12 people, and we're only running at about 60% volume. And this is despite 12 people making a lot of phone calls. We're sending MyChart messages, emails. We've blasted some of those in groups. You guys probably got some of that last week. But it's a really big challenge. And then we have to get a consent for telemedicine. That's a signed document we need. We need to get families to upload their devices, which if you're on Clarity, that's great. We just say, hey, I'm on Clarity, I'm sharing with the clinic. But there aren't other devices that are sharing like that. And so there's a lot of families who've been taught how to upload in the past, maybe when they started the pump and then they've got a new computer since then, or they never remembered uploading at all. But that's a challenge. And so our team has to tech troubleshoot with them. And then even on the call, like I had a kid this morning, it was a research study, telemedicine visit. I've done 6 calls with him at home. I've never had internet issues, and his internet was really slow. And I had a psychologist on with me as a part of the study. So she and I could hear and see each other just fine, but his internet cut out multiple times and there was an echo. And so I think we're dealing with connectivity. That's a challenge for us. And I don't know what ways around that other than like yelling at my kids and telling them that they have to get off of YouTube when daddy's working.
And Todd, I do have a question for you really fast.
Yeah.
Have you been able to reach those people who aren't able to come into the clinic twice a year? Are you having more success reaching them, or is it still kind of the same participation as you've been seeing?
So when we looked last week and we took a quick look and we saw that, so across our clinic, I just tell you like profile of people, 65% of our families are signed up on the MyChart app and are signed up on MyChart and have an active account. I usually hire college students in the summer and pay them like $15 an hour to help us out. And it's a really great position. I've really had a lot of success with that. But when you look at the kids who did telemedicine last week, 85% of those folks are on MyChart. So I think that our kids that we're seeing by telemedicine now are the families that are a little bit easier to communicate with. And then one of the things the adult clinic did was they're using an app called Jabber that allows them to call out from a BDC number from their cell phone or from their computer. I've got a Houston area code. One of the other girls, Diana, who works the Playroom, she was calling trying to get email. We didn't have anything else for her to do. We said, here's a list of people who we have phone numbers for and no email. I don't know why we have no email. We're supposed to ask this every time at every check-in, but call these people. And she has an LA area code. Katie has an Ohio. And so like we're all trained not to answer those calls, right? Thanks a lot, spammers. And so I've had 3 patients in the last 2 weeks that I know really well, and they always come and see me. They see me every 3 months, and they weren't converted over to telemedicine. And I have their email. They email me questions all the time, and I send them a message, and all 3 of them said, we didn't get contacted. And I think what it was they got a call and they didn't know who was calling and they didn't check their voicemail. Maybe their voicemail was full. So we're trying to reach out to families in different ways. Peds Clinic is going to use the Jabber app. That was an improvement we made yesterday. So we can call from a 303-724 number. I think it's going to be helpful for us. We're going to continue sending messages out. We make a first pass, calls as we go down the list. And then we're making MyChart messages in a second round. We have another two. Rhea and Katie are doing kind of the second round outgoing calls and MyChart messages and emails to families. But it's a challenge, and that's Katie's job, like outside of COVID, like pre-COVID. I brought her on the team about a year ago, and if you've ever met Katie Thivener, she's one of the most outgoing, smiley, positive people you'll meet, and she's a perfect person for the job because I need her. I said, Katie, there's a lot of families who are really struggling with diabetes. We have a criteria for people who need extra care that starts with A1C, but there's a lot of other criteria. And these are families, kids had repeated DKA events, they've had lots of no-show visits. We have a lot that we've designed. And so we gave her black and white criteria, and we said, we set this net to catch about 10% of families. I want you to run a report. I want you to go down the list. I want you to find these people and get them in for visit slots. And we'll give you special visit slots you can schedule people in. And that's what Katie does. And so she routinely, works through that list. And we still have people that we really have trouble getting in touch with and getting responses from. And so kind of taking a step back to that, the ADA says we should see you should see your diabetes doctor 4 times a year. And that probably comes from the A1C being a 3-month average. And that's kind of historically where we've been. There's not a lot of evidence that seeing you 3 times or 4 times or 2 times, does that make a difference in your A1C? We don't have that evidence, but we do know that there's a lot of families that, we average 3.02 visits per year is our average across the clinic. But there's a lot of folks that come in once a year or less, and they're struggling. And we know that if we don't get them to come in more often, there's no way we can help them. So that's the next step, is to prove that getting in actually helps. And we're trying to prove that. But that, just being connected with our patients is a challenge, and we're trying to figure out how to do that the best way. It's a long answer, but again, I can nerd out on the detail, and I love running reports, and I love, trying to figure out, like, what does the data tell us and what do we do next? So yeah, this reminds me of my next point is, like, we're all going to get COVID haircuts, right? Because what's going to happen, even if the governor, like, I gave my dog a COVID haircut, she looks awful, but I don't have to brush her now, which is great. So, even when we open the country back up, there's going to be this backlog of demand across all industries, and all this demand that's been put off, and your hairdresser is not going to have the capacity to get you in when it opens up, because they need to see the people who they would have been seeing that week, plus all the people they didn't see for the last 6 or 8 weeks or whatever before. And we're already starting to wonder about this, like, what is this going to look like at BDC when we open back up and we have patients we haven't seen in a while? And we already struggle with, if you want to get in with Dr. Alonso, because he doesn't have a ton of clinic, you probably have to schedule pretty far ahead of time. If you have 2 kids, you can email me and we'll figure it out. But I don't think the Aikmans have ever had to play that card. But I do, or maybe once. But I do, for the people that I know, try to say, I really want to get you in, and where's the flexibility, and do what we can. But I don't know how we're going to be able to meet that pin-up demand and be able to, figure that out. I think it's going to be a challenge for us. So getting set up for telemedicine visit, I'm probably preaching to the choir, talking to you guys on the call tonight. But if you have any friends you want to tell them about it, or if you haven't done a telemedicine visit yet, it's really easy to schedule. You can actually schedule a regular visit by MyChart, and then our staff will reach out to you. Usually what we're doing right now is the week of, and Dr. Wadwa made the decision this week that we really ought to just start converting the May visits. So we're probably going to work through the rest of April and just start converting the May visits over to telemedicine. You can also call the front desk, but we know how that goes. There's one phone and one person answering it. And if somebody else is on the line, you probably have to leave a message. Or you can just email Rhea or Katie directly, and they can get you hooked up. We'll send you a Zoom invite. You can upload your device. If you use like T-Connect or CareLink, you can use those, of course. I love Tidepool. If you've ever read the story about the guys who work for Tidepool, these guys are my heroes. When I think they have about 40 or 50 employees now. They used to have about 10 or 11 a couple years ago when I got in contact with them. But they're an upload platform for any diabetes device. And they went and they said to Medtronic, we would love to be able to upload Medtronic pumps. Can you give us the code so we can upload your pump? And Medtronic said, we will, on one condition, that any Medtronic pump gets uploaded, you push us the data. And Tidepool said, yeah, that's a no-go. The data belongs to the patient. We will allow our patient to opt in to push the data to you, but we're not going to just push everybody's data to you. And Medtronic said, that's a deal breaker. And the Tidepool guy said, fine, we'll just reverse engineer your code and we'll do it without you. So I really like those guys and their approach to things. And it's a really easy platform to use. And it's made for you and not for me. It's made for you to look at your data. And so I wish more of our families use that. And I really hope that, on the back end of this, that we can have more people looking at their own data to get some insights. So again, this is, preaching to the choir, but what you get out of your telemedicine visit, what I really hope, this is what I'm secretly hoping, is that as the emergency gets lifted, we're going to have to continue social distancing to some degree. And so it's really easy to make the case that we could reduce foot traffic in our building by 50% if we can cut our visits by 50% and do half of them online and do the other half in person for the people who we haven't examined in a while, we haven't looked at their growth, maybe our younger patients. If we need to, look at your injection sites that might get hypertrophied, if we need to do labs, like your yearly thyroid screening, let's prioritize to see those people in person. But for the people that live 3 or 4 hours away and we just saw them in clinic 3 or 4 or 5 months ago, let's do a telemedicine visit. And I hope that on the back end of this, what we're doing is we're writing research papers and saying that this was wildly successful, and this is the patient-centered care that we should be delivering, and don't you dare take this away from us, because our patients need this and they want this, and we can deliver really good care this way. I've been really happy with the way it's worked. It's been very smooth, and I actually run on time, if you'll believe that, because I know I have to get on a call at exactly the right time, which my patients wind up waiting for me when I'm in clinic, because I get, and I know there's a nurse and a pop-off. But I think there's a lot of really wonderful things about telemedicine. We're still doing sick day action plans. I think this is a really good time to talk about sick day. And so if you haven't seen the sick day action plan, I can show you how to find that in my chart. It should be hitting my chart every single visit, even if we don't weigh you or see you in person. And because I'm a data nerd, I'm going to show a little bit of data. Joyce Lee is she's one of my colleagues who works at the University of Michigan. Their group has really teased apart different diabetes habits, and they've gone through a lot of iterations, and they've asked this question like, just binary. Do I do the habit or I don't do the habit? What's the difference in A1C by habit? And then what % of people actually do these habits? So checking blood sugar at least 4 times a day or using CGM. The difference, you see habit 1 on the top right there, 10.4 versus 8.5. So I say to every one of my patients who's not using a CGM, let's talk about CGM, and let's see what we can do to get you on a CGM. Habit 2 is bolusing at least 3 times a day. Number 3 is using a pump. I'm not as convinced that this is actually the habit for the pump. I think this is more of people who decide to use pumps or a different group. Bolusing before meals, there's a big difference. Number 5, reviewing blood sugars at least once between clinic visits. I really wish that more of my patients would take a critical eye to their blood sugars, and I really try hard to help spend my time with my patients, teaching them how to review. And if you've sat with me in a visit, you've seen me do some of the math and say, well, I think your bolus basal ratio is a good ratio. I think your insulin carb ratio looks good, but maybe your correction factor looks a little bit wimpy. Let's go tease into that. And then so number 5 is reviewing, and number 6 is really closely paired with that. It's making at least one change between visits. And look at number 5 habit on figure 1A in the bottom there. Only about 20% of people say that they review their blood sugars between visits. And I would really want to encourage my patients, you're always, as a person living with diabetes, you're thinking in the moment, like, what do I need right now? But we really want to teach our patients to be able to be really empowered, right? So when you're disconnected from clinic and when we can't spend time going through these things together, that I want you to really feel like you know how to do this. And so if there's anything that I wish my patients could do more of, it would be looking at their blood sugars and being critical. And then I love figure 1C is like adding those habits together for each additional habit. Doesn't matter which one. If you do all 5 or all 6 or all 5 of the 6 or 4, look at the A1C difference. Once you've collected 3 or 4 of those habits, A1C is really lower. And so these are the kind of things we try to instill in our patients. So I don't pull this up during the visits, but this is the kind of thing that I'm talking about with my patients. That like, you're home from school right now, rather than being there 8 hours, you're doing 2 or 3 hours of schoolwork. Mom is not commuting and you're getting home in the afternoon and cooking yourself a dinner, like the 14-year-old I saw yesterday. Can you guys do a family meal together? What else is it from a diabetes standpoint that we could think about doing? And is now a good time to think about it? Maybe it's not. Maybe this is like, we're all crazy. We're just trying to make it through the day. But I think that this is the kind of stuff I point to my patients, which is why I kind of threw it there. And then I mentioned the prescription assistants. I was asking Paige if she had put those up. I found as I was searching around looking for these things, if you guys haven't ever run across the Beyond Type 1 website, I love their website. It's really made for people with diabetes who really want to ask good questions and reach out to the community. And I learned so much just from digging in on site like this. So they had a long page on no insurance, start here, and I think that was great. And I think that I want to see more people in the diabetes community know about this resource. So if there's anybody, if anybody's asking about what resources you read, this is a website that I point people towards. I think that was my last slide, and this is a small group. And Paige, any other chat stuff come through?
No chats yet, but I had random questions that my mind thought of that maybe you can answer for me because I'm selfish.
Yeah.
What feedback have you gotten from patients about telemedicine? Have you gotten good feedback, bad feedback? What are they trying to fix? That kind of thing.
Yeah, so we've gotten really good feedback from families, especially the folks who have to drive a long ways to come to BDC have been really happy to, gosh, I didn't have to take off a day from work. I mean, you imagine we have a really easy 6-hour driving radius, I think. I think any direction, we have a lot of patients who come from that far out. And so what that means for a lot of our families is they're taking off sometimes 2 days of work and school, because if it's a 6-hour, what they'll do is they'll maybe leave right before school is over, travel, so they'll miss pieces of 2 days before they travel back home. And so a lot of families were really impressed with how easy it was and how well it went. And the families that I've been on calls with, were really happy to be able to connect. We have not gotten any, at least I haven't seen any negative feedback from families, but there's a lot of little things that we're trying to improve. They're more like, team dynamics in terms of, okay, who's sending the Zoom link out? Where's the master calendar we're putting them? How do we keep that straight? Or do the visits need to be 30 minutes, or should we change our templates to make them 45 and give you a buffer? And then there's a lot of back end stuff about, what can we do in other states? So Wyoming is fantastic. They know they're rural and they want help. Kansas and Nebraska are not on board with that yet. And so our patients are in Kansas and Nebraska, like, if you're my patient, you're in Kansas, I'll do a visit and I just won't bill you for it. But, I want you to get the help that you need. But Wyoming makes it a lot easier for us. I actually got an emergency license in Wyoming the other day. It took 30 hours. It took 2 minutes to do an online application, and the next day the medical board messaged me. They sent me an email and said, you're good. So it's really good to see that, there's some folks that are really doing a lot to make this work well. And I really, really hope, on the, 6 months from now, a year from now, we're writing success stories up. And I hope that, insurers and payers will see this and state regulators will be on board with it too.
And then the next question, can you talk about the efficiency of doing the average blood glucose versus the A1C?
Yeah, that's a great question. So, the A1C has been a cornerstone of diabetes for going on, I guess, 30 years now, since the DCCT was published. And everybody with diabetes knows that you go get your A1C at the beginning of your visit, and everybody's so used to that. And that, serves a really good purpose. But the ADA has recently, almost, as though they were seeing the future, had recommended that we focus more on time and range. And so we even, 2 months ago at the BDC said, what kind of things how are we going to use our language differently and our note templates differently, to really emphasize to patients that time and range, that's at 70 to 180 time, is a better thing to look at. Because, right, when your A1C is, I have patients come in all the time, and their A1C was 7.0 last time, and it's 7.2 today. And mom is so frustrated. She like, it's hard for me to re-engage. Be like, no, let's have a conversation. Like, get over your frustration. Like, you're a mom of a little girl with diabetes. Like, you know, you're doing your best and you're doing great. But then when you go to have the conversation, like, it's 7.2 today. What do I do about that? I don't know. This is a 3-month report card. It reminds me of, like, I had an algebra class years ago, and I had this, the worst math teacher I ever had. We did homework assignments and we turned them in and we never got them back, and then we had to take the test. And I feel like that's almost what the A1C does to you. Like, oh, my A1C is above target. What do I do with this? So, that the time in range we're shooting for, the A1C for pediatrics, used to be 7.5, less than 7.5, but the ADA lowered that in January with the new recommendations to 7.0. Not that telling people that now you should be below 7 is going to, like, make hordes of people drop their A1C another half a point, but I think that it's because they say that this is safer, it's a good recommendation, and we're not worried about the severe hypo numbers going up if we're recommending lower A1Cs. That was the case back in the 90s, and the lower your A1C was, the higher your risk of severe hypoglycemia was. But that curve is really flattened out and dropped precipitously. It's a very, very low, not non-existent rate of severe hypo, but it's gone down a lot. So I think that, day-to-day focusing on time and range is really where we should be. And of course, it's hard when you have a patient who doesn't use a CGM and checks his blood sugar twice a week. Like, let's just talk about checking blood sugar,
Sure. Do you think the average time and range could replace A1C here in the future, or will we kind of use A1C once we get back to in-person clinic time?
I think that we're going to have a dual conversation about both. I think for my patients who are using CGM, if you're using a Dexcom, there's nobody from Medtronic on the call, right? If you're using a Dexcom, you're using your Dexcom, like, until it fails, and then you have a 2-hour warm up and you're right back on it, right? And unless you're, like, out of supplies, which happens to people. If you're using a Medtronic with the 670, most of my 670 users who are still using the Guardian are using it about 40% of the time. And I haven't pulled the clinic-wide numbers, but I feel like, if I had to throw darts, I think it's under 50% average use, and at least a third of those people have totally given up on the Guardian. And of those, a third of them aren't even using a CGM at all. So they've just given up on CGMs. And so if you're not on a CGM, it's really hard to talk about time and range. And so you really need about 6 or 8 BG checks a day with a meter for your BG average and your numbers to really approach what your CGM would show you. If you got 8 finger pokes a day, it's in terms of talking about high, low, and in range and average blood sugar, those numbers can be very comparable to what your CGM would say. But anybody checking blood sugar 8 times a day, how many of them are not using a CGM? Like 2 of them in our whole clinic. We've looked at, and just to be a nerd again, I wish I could, like, pull the slide up to show you, but we've been tracking what percent of non-CGM users check blood sugar at least 4 times a day, and that graph has gone down, 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 and now it's under 20% in our clinic, because people who are not using CGM, some of them it's because they can't afford it, and yet they're very, very motivated to do a lot of work to take care of their diabetes. But for most of our patients, they have pretty good CGM access, and those who are motivated to watch their blood sugars really carefully, those guys have moved over to CGM by and large. And so the patients we're struggling to help are the ones who are really struggling just to check their blood sugar in any way.
Gotcha. Okay, does anyone have any questions? Any other questions? Okay, I guess that is it. Well, thank you, Dr. Alonso. I appreciate you doing another video call today, your 4th one. We very much appreciate you.
Thanks, Paige. Thanks, Dana.
It's good seeing you guys.
Yeah. And we'll post this on our CDF website hopefully tomorrow, so you guys can watch it again, forward it to whoever you'd like to forward it on to, and we will hopefully see you all again very soon.
All right,
everyone be safe.
Yep, you guys be safe and take care.
Thank you.
Thank you. Okay, this is the part I never get. How do I stop this thing?